Thank you. Assalamu alaikum to everybody. Good evening. After listening so many lectures regarding embolization, coiling, stand, flow diverter, let's change our taste from endovascular to the open surgery for clipping. So I have been working at General Hospital Lahore, where I've been head of unit 2. So there is the audit of 450 cases of aneurysm clipped during that period of time. This is our Punjab Institute of Neurosciences. It comprises of about 500 beds purely for neurosurgery. It's associated with the Lahore General Hospital Lahore, which has further about 1200 beds. So as a whole, both institutions are about 1800 beds, and both work in close collaboration to each other. So this is the various specialty. There are 3 professors of neurosurgery, and then interventive group, and then many ICUs, HDUs, trauma emergency, round the clock working emergency services, which are totally elective, which are separate from the elective. There are 8 elective OT operation theatres, and there is a professor of neurology, professor of histopathology, professor of radiology, neuroradiology, and professor of anesthesia. So it's one of the biggest institute in the Asia, having so much good capacity. This is the view of the General Hospital Lahore, which is associated with our Punjab Institute of Neurosciences, and we are both working together. As regard the surgery for the introduction about the aneurysm. Aneurysm is the bulging or ballooning of the blood vessel in the brain. It look like berry hanging on the stem of the blood vessel, and it may be present with ruptured or unruptured. The incidence is various reports. According to various reports, it varies from 0.02% to 9%. And the symptom, of course, the worsening headache is the typical characteristic of the subarachnoid hemorrhage. In most of the cases, when there may be further symptom of the blurred vision, diplopia, mood changes, loss of consciousness, confusion, dizziness, and aphasia or dysphagia, other neurological deficits. So these are distribution of the cerebral saccular aneurysms. Of course, the most part of these are about 94% are located in the anterior circulation, and about 6 to 7% in the posterior circulations. These are types of aneurysm. Of course, everybody knows saccular, fusiform, dissecting. And here is the audit of our department. It has 2 setup. One is the data from 19 to 22, and other is one more previous data. In this, the objective of our vascular surgery was to study the various aspects, including the complications of the surgery and the timing of the surgery when it has to be done, which we will discuss next. These were the locations of our cases. ACOM aneurysm was the commonest on the top, 47%. MCA was the second. ICA was the third. Again, locations, genders. It was more in males in our study. This is age distribution. Mainly, it's found above 30 to 60 years of age. And these were the Hunt and Huss grading of our patient when presented, WFNS grading, Fisher grading. So I attended a conference in the Madrid of AINS in 2015. There was a lecture showing that there were the delayed ischemic changes in the brain, which were up to 28%. While I sitting and listening the lecture, I thought that these were not seen in our series. What might be the difference? Although that presentation was from Europe, which is much advanced than Pakistan. So one of my logic, which I thought was probably the most of the European studies which I saw during that conference, that they do the temporary proximal clipping. while we avoid doing the temporary proximal clipping. So that might be the difference between the results. In our results, we found only 9% delayed ischemic changes brain versus the 28% in the European studies. The difference is clear that we had used only 54%, 54% cases we used temporary clip when it was extremely necessary. In 396 cases, we don't use the temporary clip. So we keep on proceeding without applying temporary clipping. When we feel that it is difficult or when there is a bleeding, then we use only temporary clipping in selected cases. So this might be one of the reasons of this huge difference. So as a whole, in 88% cases, we did not use the temporary clip proximally to control the vessel. We clipped the aneurysm in the normal routine running vessels. So this was the onset of the new deficits, which were, of course, most of them were temporary and which recover later on. Re-exploration was done in 18% cases due to some clot formation in the craniotomy site or other, or sometime decompressive craniotomy was performed. So mortality was only in 14 cases in this huge series. So that was only 3%, while we had excellent results in 97% cases. So overall survival and outcome after clipping was satisfactory, and the learning curve of neurosurgeon was high, improved surgical expertise in the facial dissection and application of clips. And it may be reminded that during all this period of time, I gave opportunities to many young neurosurgeons to improve their learning capacities. And for example, one female neurosurgeon of Pakistan was provided opportunity to clip the 50 consecutive aneurysm clips, and she is working in Lahore. And similarly, we also provided the opportunity to clip the aneurysm to our associate professor and assistant professors under my supervision. So this was the one aspect. The other aspect, we are going to discuss the ischemic changes brain if we perform surgery within 2 weeks or after 2 weeks. So in this, again, we will have a data of 96 patients in which 2 groups were made, 48 patients each, and these are the results of that study. So in group A, which was performed surgery within 2 weeks, there were post-operative complication of 54%, and in group B, there was 37%. So these are some international studies showing the complications. They made the 3 bifurcations: day 1 to 3, 4 to 9, and 10 and plus. So generally it is believed that the period of vasospasm continues from day 4 to day 9. So our policy was not to operate the patient within these day 4 to day 9. Either we operate early or we operate the delayed. This is thus in front of you is the international literature showing the various good, poor, and death results. These are the patients who were operated after 10 days. So here is another study which we have a full-fledged given a topic of research to one of my PGR who was from Nepal, and he performed this MS thesis on this case. The surgery of the anterior circulation with and without temporary proximal clipping. Out of that, 82% patients, half cases were, that study was performed 2015 to 17. That's why that I told you that once I went to Madrid, from there I decided that we should document it, that what is the difference between the surgery performing with clipping or without clipping. In this study, there was mean age was 45.23%. Proximal temporary clip was applied only in 25 patients, that is 30%, and remaining patient was operated without temporary clipping. So post-operative ischemic changes were seen in 29% from the whole series, including those 25 patients in whom clip was applied. So the two factors were main important, that those patients where clip was applied more than 10 minutes or those patients who had age more than 50 years, they have higher chances of getting the post-operative ischemia and vasospasm. But in our policy, it was that if you have to apply temporary clip for longer period of time, our policy is that we remove the clip after every 3 minutes. We will let the circulation to continue for a few minutes, and after that we can apply it again when it is required. So these were the conclusion of that study, and where again it was shown that the better results are those where you don't apply temporary clip and where you proceed those. So with this, I will just, we had started vascular fellowship program where young neurosurgeons from all over the Pakistan participated, and they were the key part of this team, who were given 3-month rotation time for learning the vascular surgery. These are few cases. I'm not showing the video due to lack of time. That's what our department where we had performed the vascular fellowship. Thank you very much. Here just I will request to my all these endovascular colleagues that the time where even you should not intervene the patient, according to my opinion, that is those patients having severe headache, and the time period between day 4 to day 9. If the patient is having severe headache between this period, day 4 to day 9, this means the active vasospasm is there, and you should not touch the patient. However, if the patient is stable in grade 1, and you can proceed. So if you wait for a few days, from day 4 to day 9, after that you perform the even endovascular procedure, you will see the big difference in your results. The ischemic change in the brain will be extremely less if you avoid this period of vasospasm. And headache is the most common indication of vasospasm in these cases. Thank you. This is our journal of Pakistan Journal of Neurologic Surgery. So I invite all our faculty members that if they want to send any publication, we will welcome you here.
Okay. Due to shortage of time, we will have only 2 questions, please.
Yes.
I have a short one.
Yes, yes.
I would like to ask you, what do you do with the patients that you suspect have vasospasm?
That is typical triple regime, borderline hypertension, hypervolemia, and we keep the patient relaxed, and you should give the hypertonic saline, 70% dextron or these things, so that the diabetes of the RBCs become better, and you should give them good care for those few days.
In addition,
the nimodipine is the standard we give every patient.
My point was